laptop. Let's just go straight from that. Okay. That's good. He's got it loaded and ready on his laptop. So is it plugging the laptop in will be the way to go?
I'm not sure.
HDMI or VGA?
It's an IP, it's a PC.
Yeah. It's not reaching well.
Sorry?
This plug is not reaching well, so there's very slight connection.
It is loaded up bags.
You see, it's not touching it, barely.
That looks promising.
Yeah, be careful. This is only touching. I can't even get a lock on it.
Okay.
I can't even get a lock on it.
Oh, okay.
So it might come off. So be okay. I can poke it.
No, it's got USB not recognised.
So that's an inch. So I'm just pushing it again. So
Oh, okay. Yeah.
Now, if you want to, would you like to move around? Would you like a lapel mic, or will you stay at the
I'll stay. Thank you.
Yeah, sure. We've got a couple of roving microphone attendants. Fantastic, thanks, Kate.
yes, wonderful.
Okay, I'll just give everyone 10 seconds to get themselves comfortable in their seats. Look, the organisers are delighted today to present today's keynote session, and we're equally delighted to have Professor Peter MacDonald present it. Peter is Conjoint Professor of Medicine at the University of New South Wales. He's the Medical Director of the Heart Transplant Unit at St Vincent's Hospital, that's in Sydney, and Head of Transplantation Research Laboratories at the Victor Chang Institute. He's the past President of the Transplantation Society of Australia and New Zealand. He has major research interests over the last 25 years has been in areas of heart failure, pulmonary hypertension, transplant, allograft rejection, donor management and organ procurement and preservation. He has publications in over 250 peer-reviewed scientific journals and papers, 8 national guidelines, 15 book chapters. He was nominated for the Australian of the Year Award in 2010, 2015 and 2016. 2017 must be your year, Peter, I think. In 2015, his research into recovery and transplantation of hearts from DCD donors was recognised by the New South Wales Government's New South Wales Minister Award for Cardiovascular Research Excellent, and by the ACT Gift of Life organisation with the Terry Connolly Award for Healthcare Leadership and Innovation. It's an absolute pleasure to have Peter here today. His presentation is entitled Mending Donor Hearts Using Machine Perfusion to Increase Heart Transplant Opportunities and Outcomes. Thank you, Peter.
Thank you, James, and thank you for those kind introductory words, and thank you for inviting me to participate in this symposium. I've really enjoyed the presentations that I've listened to this morning. What I want to do in this talk is give you all an overview of heart and lung transplantation as it's currently performed in Australia and New Zealand, talk about the changing profile of donors, in particular the change of donation after brain death or the change in that profile of donor, and also donation after circulatory death. And then talk about our research of how we've gone about looking at preserving and reanimating the heart after death, particularly in the DCD environment. So this is a snapshot of the heart transplant programs that are scattered across Australia and New Zealand. There are 5 adult programs. You can see 3 on the eastern seaboard. There's one paediatric centre based in Melbourne, and there's one paediatric centre based in Auckland. You can see the numbers there since St Vincent's was the first program that was established in 1984, and you can see that as of the end of last year there were 2,714 heart transplants that are being performed by those centres. Somewhat disturbingly for me, lungs have overtaken hearts, even though they started later. You can see there's now 2,800 lungs, and if you count heart lungs, there's now over 3,000 lung transplants that are being performed over that time. The good news is if you have a heart transplant in Australia and New Zealand, you do quite well compared to the international benchmark. And the blue curve that you can see there is international registry data. There's an international society that basically collects survival data from virtually all transplant programs around the world. And you can see that that survival curve is based on almost 120,000 heart transplant recipients covering that period 1982 through to 2015. And the black line is the curve for the Australian and New Zealand cohort, and we actually contribute to the blue line as well. But you can see that if you're in the international survival curve, that your chances of surviving, or your median survival after a heart transplant is 11 years. In Australia and New Zealand, it's 15 years. And this is all data since we first started doing transplants. We'd now think that the median survival after a heart transplant is probably 20 years in Australia. Now, if you're a 50-year-old and needing a heart transplant, 20 years sounds pretty good, but if you're a 15-year-old, 20 years, you're still only 35. So although it's a very effective therapy, it still obviously has limitations. I think one of the very positive stories to come out of the last decade has been the improvement in Australia's organ donation rate. This is deceased organ donation rate. And that really did coincide with the establishment of the Australian Organ and Tissue Authority back in 2008. And you can see that in the last 10 years, Australia's deceased organ donation rate has doubled from 10 to 20 donors per million. We're still a long way short of the world's sort of exemplar, which is Spain, which is now in the high 30s. But Spain undertook a similar reform of their procedures, and they took about 20 years to get to where they are after starting from a similar baseline to us. So I think Australia are well on the way to achieving that. If you look at what's happened in terms of cardiothoracic transplants over that period of time, the blue bars, the light blue bars are heart transplant numbers on a year-by-year basis. The red bars are lung transplants. And the thing that's immediately obvious when you look at the current era, since the establishment of the authority, there's been a doubling of lung transplants, but very little change, at least up till 2015, of the actual number of heart transplants that have been performed. Now, why is that? The first reason, or one of the reasons, is the changing profile of donors, and this is looking at donor age distribution, dividing donors into triennia, or into 3-year brackets, and you can see the most recent bracket is onto the right of each of those histograms. And you can see that there's been an increase across all age groups, but by far away the biggest increase has been in the older age groups. And in our own practice, we rarely would consider donors over the age of over the age of 60. But in lung transplantation, they now accept donors up to the age of 75. So that's clearly had a significant impact on lung transplant activity, but really hasn't impacted very little on heart transplant activity. This just shows you our own data from St Vincent's, looking at the distribution of donor age across the first 30 years of our program, 3 decades. And you can see the green bar is the most recent decade, and you can see that there's clearly, even within our program, there's been a significant shift towards using older donors. And in the most recent era, the 2004 to 2014, about 25% of our donors are over the age of 50. Now, when you're talking to someone who's come to be assessed for heart transplantation, and you explain this to them, they say, well, yeah, I'll have a 20-year-old motorcyclist, thank you. But we do try and make it clear that we do transplant older hearts. We would try to transplant older hearts into older donors, but that's it depends. Older donors into older recipients, but that depends to some extent on the urgency of the recipient. The other sort of issue that we face, particularly in Australia compared to other jurisdictions, is what's known as the ischemic time, which is the time between when the heart is cross-clamped in the donor to when that cross-clamp is released in the recipient. That total time is called the ischemic time. Most of that time is spent in the transport of the donor organ from the donor hospital back to, in our case, St Vincent's, and most of that time the heart has been in the ice bucket. But you can see that this is data, this is international registry data, looking at the risk of 1-year mortality after a heart transplant, plotted against ischemic time. And as you can see, that up to about 200 minutes, there really isn't any impact of ischemic time. But as soon as the ischemic time goes over that 200-minute mark, you can see that there's a progressive increase in the risk of mortality at 1 year. So that if you go from 3 hours to 6 hours or 360 minutes, you can see the risk of dying within the first year after a heart transplant has actually doubled. Now, what I've shown in these vertical dashed lines are the average ischemic times for hearts transplanted in these different jurisdictions. So in Australia, our average has been 4 hours. So we're already facing an ischemic time challenge. And I don't have time to go into it now, but there's a very powerful interaction between increasing age and increasing ischemic time, contributing to increased risk of graft failure. Now, as I mentioned, the traditional way of transporting donor organs, such as the heart, has been basically in an ice bucket, and you're relying on deep hypothermia to slow the metabolism of the heart to a very low level, and thereby protect it in that way. But the trouble is that although it slows the metabolism, it doesn't stop it altogether. So there is a limit to the benefit you can achieve with cold storage. So that's really led many groups, not just in hearts but in other organs, to look at what's really become known as machine perfusion of organs, putting an organ on some perfusion rig where you provide an oxygenated solution for that organ. And in the heart context, the two basic approaches have been what are called hypothermic perfusion. So again, this is the organ is kept very cold, but you use an oxygenated solution. It doesn't have to contain blood because the metabolism of the heart is so low, so it can be a crystalloid solution if you're using cold perfusion. And Frank Rosenfeld, who's shown in this photo, has been one of the sort of pioneers of this approach. But the other approach, and one which has now actually been evolved in clinic or emerged into clinical practice, is what's known as normothermic perfusion, and this is where the heart is perfused with blood which is obtained from the donor. The blood is warmed up to body temperature, and that heart is will then be beating on the machine. And you can see there that there's a case report of a retrieval of a heart from Darwin back to Perth on this machine rig, with a total retrieval time of 11.5 hours, which is sort of way beyond what we would consider in an ice bucket, and that heart functioned very well. So this shows you a heart on the heart in a box, so-called, or a heart, and you can see that there's a cannula going down retrogradely into the aorta. So blood is actually being perfused retrogradely down the aorta. The aortic valve is closed, which means all the blood goes through the coronary arteries, returns from the coronary sinus back to the right heart. The right heart is sewn over, or while the heart's on the machine. So the heart is then ejected, or the blood is then ejected into the pulmonary artery, which is coming out through that red line there and going back to a reservoir, and then it gets recirculated. There's also a vent, that air-containing line, which is venting the left ventricle. So in this configuration, the left ventricle is beating, but it's not actually doing any work. So this is a non-working heart. The chamber that you can see working, which is on the right of the picture, is actually the right ventricle, which is actually ejecting the blood that's going through the coronary perfusate. So there's been two sort of concepts of applying this technology. The company that developed the machine, Transmedics, surprisingly enough, want everyone to use it on every case. And they actually did a trial which was published in The Lancet back in 2015, where they basically took optimal donors and randomised them to either normothermic machine perfusion versus cold storage. And they basically shot themselves in the foot to some extent, because what they found was that the outcomes were basically the same. So I think the take-home message was that you don't need this technology for all donors. The other approach has been to look at it in the context of what we call high-risk donors. If you've got a donor that's going to be facing a very long transport time, or a high-risk recipient, if you've got a very complex explant where the surgeon thinks they may take a lot longer than more straightforward cases in removing the heart. If the heart's back in the operating theatre while the surgeon's trying to struggle to get this heart out, and if the heart's in an ice bucket, that just adds another level of stress to the surgeon. Whereas if it's on a machine and the surgeon can feel quite confident this heart is well protected. And the group at Harefield who have really adopted that approach, and that's a publication from their group on the right. And they reported very excellent outcomes using this approach. But this was all non-randomised, uncontrolled observational experience. So it still left people asking the question, do we still need this technology? Now we've adopted this, the Transmedics technology, and within the brain-dead population, we've applied it to 12 hearts that we've retrieved so far. 2 of them we rejected, one because of severe angiographic coronary disease, and one of the advantages of this technology is that you can actually do an angiogram with the heart on the machine, and we did that and demonstrated that. And the other is looking at unfavourable metabolism, and I'll show you an example of that. But we've transplanted 10 of these hearts with very good outcomes. And these were hearts that were by and large would have been, had been or would have been rejected by the other centres. And just to give you one example, this is currently in press. This in 1 week in 2015, we were offered a donor from Perth and a donor from Darwin, and the one from Perth was retrieved for us by the Perth unit, who put it in an ice bucket, sent it to us, and we transplanted it. The recipient spent the first 3 days on ECMO while the heart was recovering, had various ECMO-related complications, spent 20 days in ICU, 50 days in hospital, but ultimately has done extremely well. The second donor, there's no team in Darwin to retrieve it for you, so we sent the team there. We sent the machine and put the heart on the machine, brought it back, and transplanted it. That recipient spent 2 days in ICU, 13 days in hospital, and was discharged well after 13 days. We did a cost analysis of these 2 transplants, and the one from Perth cost the taxpayer $230,000 for hospital costs, and the one from Darwin, including the cost on the organ care system, cost just under $100,000. So people sort of shudder at the upfront costs of this technology, but if you apply it in the right setting, it can prove to be cost effective. The main way of assessing the quality or the viability of the heart on the Transmedics system is to actually measure the blood going into the heart, into the coronary artery, and then coming out through the coronary sinus. So there's sampling ports across the coronary vascular bed. And if the heart's happy, if it's non-ischemic, it will actually extract lactate and actually use lactate as a metabolic substrate. If, on the other hand, the heart is ischemic, like any ischemic muscle, it will generate lactate. So the lactate levels will increase, and the coronary sinus lactate, the blue bars, will be higher than the red bars, and that will tell you that this heart is unhappy. And that's been the sort of approach that's been used to validate the quality of these hearts while they're on the system. And the red horizontal bar is 5 millimoles per litre, and that's sort of the threshold. And if this lactate level in the system is under that and the heart's extracting, they've been the two main parameters that have determined the suitability of the heart. This is a coronary angiogram, which you can't see because it hasn't projected, but this is, we can actually do a coronary angiogram while the heart's actually on the system and demonstrate whether or not there's disease. The other major change in donor characteristics, I talked about increasing age of deceased donors. The other big change has been the pathway to deceased organ donation. The traditional or pathway has been known as the brain death pathway. The more recent pathway, although it's actually a rebirthing of something that was there at the very start, is the so-called donation after circulatory death, or DCD pathway. And you can see that over the last decade here, up to 2014, there's been a small increase in the brain death pathway, but quite a dramatic increase in the DCD pathway, and that's actually continued to increase in the last few years. And if you looked at organ transplants that were conducted, that were performed from these DCD donors, you can see that this is 2014 data, very big impact on kidney transplants, quite a big impact on lung transplants, so again accounting for this increased lung activity in recent years. Less so on liver transplants, and even there's the occasional pancreas transplant from this type of donor. The one organ that's been missing from this slide has been the heart. Now, if you look at the legal definition of death in Australia, and this is how it's defined in all states and territories, the brain death pathway legally is irreversible cessation of all functions of the brain of that person. The DCD pathway is irreversible cessation of the circulation of the blood in the body of that person. Now, where we as a sort of a medical community have got ourselves into trouble is where we've used very sloppy language, and instead of saying donation after circulatory death, we've actually used the term donation after cardiac death. People will say, well, how can you then transplant a heart from someone who's gone through cardiac death? And cardiac death is a misnomer. The heart, like the liver, like the lungs, like the kidneys, has stopped working in this after circulatory death, but it hasn't died. But we really have created a problem, and it's an obvious source of confusion for not only the general public, but for the medical and nursing community and allied health communities when they see this. And to sort of compound this problem, we have official documents put out under the auspices of the Organ and Tissue Authority, and these are in urgent need of revision. But this is, if you go to the website and download their documents, you'll find that there is a national protocol for donation after cardiac death. And then there's a plain language statement to confuse the general public as well. But these are wrong, and they need to be revised. If you look at the two different pathways, with the brain death pathway, there's invariably severe brain injury, loss of all brain functions. There's a series of events that occur after as a consequence of that. But the heart is beating in the brain-dead patients. Patients in an intensive care unit, and you can make an assessment of the heart and prior to removal of the heart. And as I've shown you, cold preservation has generally worked quite effectively within the time frames that we perform this surgery. With the DCD pathway, there is usually, although not invariably, severe brain injury, but there is some residual brain function. So this person cannot be determined to be dead by the brain death pathway. So under these circumstances, the person has usually suffered some catastrophic brain injury, and the intensive care specialist will have a discussion with the family and recommend withdrawal of life support because of futility. And now, if the family then agree to that, then there will be a discussion about organ donation after that decision has been made. And under those circumstances, at a time that's agreed by everyone, the ventilator will be turned off, any drugs supporting the circulation will be stopped, and they'll wait for the heart to stop beating, and then they'll wait a certain amount of time to make sure that nothing restarts, and then at that point they will declare death. And then at that time, the donor, if they're a consented donor, if it all happens in the intensive care unit, they'll be rushed round to the operating room, and all the organs that can be retrieved and, for transplantation will be done, and will be done very quickly and very urgently. But under this circumstance, there's a period of obligatory warm ischemia. You can't avoid it during withdrawal of life support. And this applies to all the organs, but the heart is particularly susceptible to this warm ischemic injury. The duration is uncertain. You're never sure how long this process will take before the circulation stops completely. And then if you've got an arrested circulation as far as the heart goes, how are you going to assess that heart to see whether it has a potential to recover if you then remove it and transplant it? And how are you going to preserve it during that process? Now, DCD, heart transplantation from DCD donors isn't a new phenomenon. The very first heart transplant was technically a DCD donor. The donor in this instance was unquestionably brain dead, but brain death legislation didn't exist in 1967. And just as an aside, this will be the 50th anniversary of that transplant this year. They actually waited for that heart to stop beating before they actually removed it, and then they took it straight from one operating theatre next door, transplanted it straight away with a minimum amount of ischemic time. Then in 2008, there were 3 DCD heart transplants performed in paediatric recipients, and these were co-located donors and recipient, one operating theatre next to the other. There was a lot of controversy around these cases because of the time that they actually waited. In 2 of the cases, they waited 75 seconds after cessation of the circulation before declaring death, removing the heart and taking it next door. They also performed a whole range of ante-mortem interventions, cannulation and other things, and this created a whole storm of controversy. And then in 2009, the group at Papworth, with a DCD donor, actually instituted ECMO in the donor after the circulation had been ceased and death had been determined, and and they were able to restart the heart and restart the circulation in this donor, while at the same time cross-clamping the head and neck vessels to prevent recirculation to the brain. And again, this provoked a storm of controversy, particularly when I spoke to intensive care colleagues here. They said if we tried to do anything like that in Australia, we'd, 1, be accused of murder, and 2, they wouldn't have a bar of it. So we thought if we're going to try and recover these hearts, there was no way that we could try and restart the heart in the donor after death had been determined. Now, I'm not sure if this will work, but we modelled this in the pig, and so this is what happens with withdrawal of life support in a porcine model, and this is a heart at baseline, and you can see this area here is the right ventricle, and below that is the left ventricle. As you withdraw life support and the blood pressure falls, you can see that the heart is obviously becoming bradycardic, but this right ventricle is becoming quite markedly distended. Then there's a period where you progress to complete circulatory arrest, as shown here, and then there's this mandated standoff time to make sure that nothing, that there's no what's called auto-resuscitation. And that's something that varies from state to state, as I'll show you later. But it's only at the end of that whole process that you can flush your heart with your cardiac preservation solution. But all that time, the heart is ischemic. So this is the warm ischemic challenge that we face in transplantation. And there's a group, Darren Freed and colleagues in Edmonton in Canada. They've modelled this using cardiac MRI, and this is just an image from their paper, again looking at a pig model, and you can see the RV, right ventricle labelled there, how it's become grossly distended at the end of withdrawal of life support. And we've actually modelled it as well, and this is work done primarily by a PhD student, a surgical PhD student, Hong Chi Chu, looking at the pressure changes, and we put catheters into the left atrium, the right atrium, pulmonary artery, and we looked what happened to these pressures. And the red curve is the pulmonary artery pressure. So you can see that when the ventilator's turned off, there's this immediate rise in pulmonary artery pressure, which we interpret as pulmonary vasoconstriction. The blue bar is the right atrial pressure, and you can see that pressure is increasing in parallel with the pulmonary artery pressures. The black line there is the left atrial pressure. Left atrial pressure is actually falling, and this tells us this is pulmonary vasoconstriction. So the increase in the pulmonary artery pressure isn't from left ventricular failure, it's actually from pulmonary vasoconstriction. And we think that's what's causing this gross distension of the right ventricle following circulatory arrest. So when you withdraw life support, you have obviously normothermic ischemia, which applies to both ventricles, but you have an additional insult occurring to the right ventricle in the form of RV distension. And we thought we needed to bear this in mind if we're going to try and translate this or transplant these hearts. So in working out what we thought the steps were towards clinical transplantation of DCD hearts, we needed to work out some way of minimising the damage that occurs during withdrawal of life support. We needed to optimise the organ preservation during transport, and we needed some way of assessing these hearts that have been arrested prior to transplantation. So we formulated a series of hypotheses, and this became the PhD project of another surgical PhD student, Arjun Iyer, and he's just had his PhD awarded, so you can see the experiments worked out. But the hypotheses we formulated were firstly that a phenomenon that we call pharmacological post-conditioning will reduce myocardial ischemic injury and prolong the time that the heart can tolerate warm ischemia. The second was that ex vivo myocardial perfusion, machine perfusion, would provide superior preservation than cold static storage. And thirdly, that the use of normothermic perfusion would allow us to assess the viability of these hearts and know whether it's safe to transplant them. Now, what do I mean by pharmacological post-conditioning? This is based on a phenomenon that's been around recognised for a long time. And if you take a heart and you subject it to a prolonged period of ischemia, shown by the black bar there, and then reperfuse it, you will suffer, that heart will experience a myocardial infarct, there'll be contractile dysfunction, there'll be arrhythmias. Now, a group in the 1980s was studying the phenomenon of pre-infarction angina, so recurrent brief episodes of ischemia prior to a prolonged insult. And their hypothesis was that if you had pre-infarction angina and then you had an infarct, you'd have a bigger infarct than if you didn't have pre-infarction angina. And what they actually found was the opposite of that, was that the ischemia occurring just prior to the infarct actually led to a reduction in the infarct size. This was in an animal model. And then almost 20 years after that, another group actually applied what was called ischemic post-conditioning. So at the end of the ischemic insult, they had brief episodes of ischemia reperfusion. and then were able to demonstrate a protective effect. And we thought this post-conditioning phenomenon was something that we could apply in the DCD donor to try and protect the heart. But we couldn't be clamping and unclamping the aorta in this context. We wanted to pharmacologically mimic this if we can. And this next slide summarises work from multiple laboratories around the world looking at the signalling pathways which are thought to underlie these mechanisms of pre- and post-conditioning. But there are two main pathways. One's called the risk pathway, the reperfusion injury salvage kinase pathway, and the SAFE pathway, the so-called survival activating factor effector pathway. But the target for both these pathways is thought to be the mitochondrium, and what activation of these pathways does is prevent the formation of a hole in the mitochondrium, which then just has all the mitochondrial contents just spill out, activate necrosis, apoptosis, and other death mechanisms in this cell. So these, and we've been working in our lab at the Victor Chang using both small and large animal models to look at myocardial preservation. And this slide summarises a decade of research in our laboratory where we've looked at various drugs or supplements to preservation solutions which either singly or in combination activate different elements of these, the signalling pathway. To give you one example, this is a combination of three different agents: erythropoietin, glycerol trinitrate, and a drug called zaniparide, which is a sodium hydrogen exchange inhibitor. And this is looking at isolated rat hearts stored for 10 hours in cold storage and looking at recovery of these hearts with single supplements, dual supplements, and triple supplements. And you can see that there isn't any single bullet. It's a combination of approaches which actually leads to the best recovery with the triple therapy. So we thought this was the combination that we would apply to a DCD model of heart preservation. So we set up our own Normothermic Ex Vivo Perfusion system in the laboratory. So this is a blood perfused heart taken from a pig, and if we measure that heart, we can measure its performance in an in vitro setting. So if you anaesthetise the pig, don't put it through any stress, but just remove the heart and assess the heart on a perfusion system such as this. This shows you the cardiac output of that heart over a 4-hour observation period. If you withdraw life support, let the animal arrest, which will happen within about 5 to 10 minutes, then remove the heart at 15 to 20 minutes after arrest, these hearts still recover fully without just using an unsupplemented preservation solution. If you wait 30 minutes and then put the heart on the rig, you get a dramatic fall off in recovery, and if you wait 40 minutes, you get no recovery. So this gives you a sense of how quickly the heart deteriorates following withdrawal of life support. So what we then did was to compare a series of hearts where we had supplemented the hearts with this triple agent that I mentioned, and that's the brown bar at the top, and compared that to the red bar, and this is 30 minutes of ischemia, and you can see with the supplemented solution we could get better recovery of these hearts. And similarly at 40 minutes we could get better recovery of these hearts as well. So if you go back to what I just showed you, that curve, when you superimpose all these curves, what we could show that by supplementing the solution, we could get basically 10 minutes better tolerability of ischemic time. So we could have hearts that had been arrested for 30 minutes and have full recovery of these hearts. Now 10 minutes may not sound like a long time, but with recovery of livers from DCD donors, the limit of ischemic time they set is 30 minutes. So we thought with 30 minutes with cardiac recovery, we're in a position where we can recover these hearts in a clinical context. So we published that a few years ago now, and I think the important concept is that it is possible to intervene after death to actually protect the heart, and you don't need necessarily to apply antemortem interventions. The next step was then to transplant these hearts and see if we could get better recovery of them, but instead of using our home-built system in the laboratory. We use the Transmedics system to preserve these hearts, having put them through this 30 minutes of ischemia. So then we did a series of experiments comparing the Transmedics to the cold storage, and we stored these hearts either in cold storage or on the system for 4 hours, which matches our clinical timeframes in heart transplantation. And if you looked at the lactate profiles of these hearts, you can see that of 8 hearts that went on the rig, 7 of them actually showed what we regard as a viable metabolic profile. This is having gone through 30 minutes of withdrawal of life support. There was 1 heart that performed badly, as you can see there, and that heart actually looked terrible on the system. We then went, we didn't transplant that heart, but maybe we should have to prove the point. But with all the cold stored hearts, and we only did 3 of these, none of those recovered when we transplanted them, and none of them looked like recovering. Of the 7 transplants that we performed, we had 2 technical disasters, which happens in the laboratory from time to time. But we were able to complete 5 successful heart transplants in the laboratory, and all these hearts basically worked. They needed various levels of support, but what would be considered clinically relevant doses. And as I mentioned, none of the cold stored hearts survived. So then we published that the following year. The next step then was well, that's all very well in the context of to do that in the laboratory, but you know the whole aim of this exercise was to translate this into clinical practice. So the next step really was to start recovering human hearts in a DCD environment and see if we could evaluate these and demonstrate viability. Now, it wasn't, having made that decision, it simply wasn't a case of going to the next DCD retrieval and saying we're here to recover the heart as well as the lungs and all the other organs. There was about an 18-month period of engagement of really all the key stakeholders in this area, particularly the intensive care specialists, who almost invariably were very enthusiastic about us recovering hearts from these donors, providing we didn't do anything to alter their processes of determination of death of these potential donors. We had to get the agreement of the abdominal transplant retrieval surgeons because we need to remove donor blood before they give any of their preservation solutions. And that takes about 1.5 minutes to remove the blood that we require. But in this context, every minute counts. We obviously needed our Research and Ethics Committee. We needed to notify our State Department of Health and also the Organ and Tissue Authority and get agreement basically at all those levels before we proceeded any further. So I actually approached 10 ICU specialist colleagues across the state of New South Wales, asking, and as I said, they're all quite enthusiastic about participating in this. And we set up these donor criteria for a DCD donor. And I won't go through them in detail, but you'll note the upper age limit was set at 60. Now, about a week after I gave a presentation at one of our hospitals in Sydney, I was called by the intensive care specialist and said, we have a 62-year-old donor. Would you be interested in recovering this heart? And this was a very unusual circumstance. This individual had relapsed Guillain-Barré syndrome and was totally paralysed and had been on a ventilator for something like 6 months and basically requested withdrawal of life support. But in doing so, he wanted to donate his organs for therapeutic purposes or research if that wasn't possible. So the only other organs that were considered in this individual were the kidneys, and they were retrieved and transplanted. But this person offered his heart for research, and so we did go and retrieve it. What I've shown you there is the time from turning off the ventilator to arrest the blood collection, the flush, and then establishing the heart on the rig. And you can see these were the lactate levels. The lactate levels were quite high, but falling. We actually use a little ISTAT cartridge as a point of care way of measuring the lactates in the system. And then we ran out of cartridges after the 4th hour. And again, that happened sometime in research. But we brought this heart back to the laboratory and looked at its performance. So this shows the pressure that was being generated by this heart in response to increasing left atrial pressure. So it's like a Starling curve. And this is the cardiac output. This wasn't a normal performance by any means, but this heart was definitely alive and functioning. And so this is the heart on the rig, and this is in response to dobutamine, and you can see this heart was contracting and viable. So we then we did 2 further retrievals, both very unusual circumstances, and you can see that the second donor, the lactates looked terrible. They all went the wrong direction. In the third one, the lactates were going in the right direction until we made the heart do some work. And then as soon as at this arrow at the bottom, and you can see as soon as we made the heart work, the lactate levels started to rise. But as I say, we knew from this early experience that, that sooner or later we were going to find a heart that met viability criteria. And the question was then, should we transplant it? And the intensive care colleagues were as much as they were prepared and happy to collaborate with research, they'd much rather we use these hearts and transplant them if we could. Now, the additional considerations were that zaniparide is not approved for human use, so we weren't able to use that if we'll apply this clinically. And Celsial, which is the solution we use in the laboratory, was not recommended for a combination with the normothermic perfusion device. But we're in disagreement with the company about that, but we decided we would go with St Thomas's solution, which is an alternative preservation solution, supplemented with erythropoietin and GTN. And with that solution, we decided to then amend our study protocol. We took a much more conservative approach in terms of donor age. So we said we would accept donors up to the age of 40, warm ischemic time less than 30 minutes based on our laboratory work, and a viable lactate profile on the organ care system. We amended our case report form. We had the marginal heart study in place for brain dead donors. We adapted that for DCD donors, and that was with the help of Julie Letts, who was an officer working in the New South Wales Department of Health at the time. So this is the protocol that we established for retrieving hearts from the DCD donors. Almost invariably, the donors do not receive heparin, although that's something that varies from state to state. As I said before, no attempt was made to re-establish the circulation after death. By actually draining the blood off very quickly, which we can do with a large bore cannula in the right atrium, you actually rapidly decompress all the organs, not just the heart, but the abdominal organs as well. We then administer our flush solution, explant the heart, and then the other organs as well. So the first heart that we transplanted from a DCD donor was this from this 26-year-old male donor who had suffered a critical hypoxic cerebral injury. He'd actually hung himself and had sort of survived the hanging, but had catastrophic brain injury. He'd been in the intensive care unit for a number of days. He'd had an echocardiogram prior to withdrawal, or 2 days prior to withdrawal of life support, and that showed normal heart function. He went through withdrawal of life support. We were able to infuse our solution by 28 minutes, so within our 30-minute time frame. And the heart, and importantly, the lungs, liver, and both kidneys were all retrieved and transplanted from this donor. So in retrieving the heart, we hadn't adversely impacted on the other organs. This shows you the lactate profiles of this heart. This heart initially looked very unwell, but recovered quite dramatically over the next 2 hours. And within 2 hours, this heart had met our viability criteria, and we decided to then proceed and transplant that heart. The recipient was a very straightforward recipient. It was a woman who was in her 50s. There was an obvious weight advantage for the donor. She had a familial dilated cardiomyopathy, had been very sick with recurrent admissions for acute decompensated heart failure, but importantly had not had any previous surgery, and she had a very low transpulmonary gradient, which means that she had a very low pulmonary resistance, which means that the transplanted heart wouldn't be facing, the right ventricle of that transplanted heart would not be facing a very high load in the new environment. This shows you the heart at day one, and this heart after transplantation was initially very stunned, as you can see, and she actually came out of theatre on ECMO, which was a great concern, but within a few days this heart had fully recovered, and you can see by 1 week post-transplant this heart, this is a short axis view of the left ventricle. This heart's very small and very hyperdynamic, and she is now over 3 years post-transplant and still going very well. We do routine myocardial biopsies at between day 7 and day 9 to look for evidence of rejection, but we can also pick up evidence of ischemia reperfusion injury, and this heart actually looked quite normal on biopsy at day 8. We then did 2 further transplants, and we submitted a paper to the New England Journal based on, they had published the 3 paediatric cases in 2008. They said no, this wasn't important enough, so we then approached the Lancet, and they said they'd take it, and we published our first 3 cases in the Lancet. This shows you our experience currently, and we've now attended 35 DCD withdrawals. Importantly, not all DCD withdrawals progress to death, at least within the time frame that we require and our liver colleagues require to retrieve these organs. And you can see 1/3 of these didn't actually progress within the time frame for us to use. Of the 23 that did, the first 3 I showed you were for research, but we've now retrieved 20 hearts with a view to transplanting these hearts if they met viability criteria, and 15 of them we have transplanted, including there was 1 which we retrieved from the ACT. 5 of the hearts were deemed unsuitable, 3 because of clearly unsatisfactory performance on the rig, and we had 2 machine failures, which underlines that when some things can go wrong with machines. So the attraction of an ice bucket is it's very simple, not a lot can go wrong, but once you introduce complexity, things can go wrong. This shows you where we've been to retrieve these hearts, and you can see we've been as far as Darwin to retrieve a DCD heart, and that heart worked extremely well. And we've been mainly to Sydney and Melbourne, as you can see there. This shows you the pattern of the donors. This is the first 11 donors. Most of them have been traumatic brain injuries. A few of them have been hypoxemia. Not all of them have echoes prior to donor referral, and we don't request that, and to do an echo after referral is considered to be an ante-mortem intervention, so we don't request it. But given the donor characteristics, we expect that most of these donors will have normal hearts. This gives you a sense of the time frames from withdrawal of life support to stenotomy and cardioplegia in the hearts where we have retrieved the heart. So on average, the time from cessation of ventilation to circulatory arrest has been 10 minutes. From circulatory arrest to determination of death, it varies. In New South Wales, they allow 2 minutes. In every other state, they allow 5 minutes. So there's interstate variation in how long you have to wait, and that's mandated by law. Then from determination of death to knife to skin, and this is basically the time it takes to transfer the donor from the intensive care unit, if that's where withdrawal has taken place, onto the operating table and have the donor prepped, is 4 minutes. And then from knife to skin to actual administering the cardioplegia, so this is taking out the, removing the blood and then fusing the cardioplegia. The surgeons can do it in 4 minutes from when they make their initial incision. This shows you the actual times that these hearts have spent on the actual organ care system. And as you can see, it's ranged from the most recent one, you can see it was 141 minutes, but the one from Darwin was 410 minutes, so close to 7 hours on the machine. These are the recipients for the first 11 that we've performed, and the first 6 cases were very straightforward cases. They're all what we call clean skins. None of them have had previous cardiac surgery. But from then on, the pressure was to use this, to apply this to all the people on our waiting list. So you can see that patient number 7 had a biventricular assist device in, and most of the others have had previous cardiac surgery as well. So we've been using these hearts for anyone that's on the waiting list now. If you look at the outcomes, again, this is for the first 11 patients. The main sort of difference with this group of patients has been the higher reliance on ECMO for the first few days post-transplant, and you can see that 3 of those first 11 patients have needed initial ECMO support to allow the heart to recover. Now, if you look at DCD kidney transplantation, there's now a very big experience with DCD kidneys. The big difference between the DCD kidney and the brain-dead kidney is that you have a higher rate of delayed graft function in the DCD kidney compared to the kidney from a brain-dead donor. But their long-term outcomes are exactly the same. And this is, I think we're seeing a very similar phenomenon here with the heart, a higher rate of delayed graft function in these hearts, but they'd all, as you can see, at cardiac function at 1 week, they all recover fully. With follow-up at 1 year, we've had no mortality in the patients to date, and they've all been functional class 1 with normal graft function, and they've behaved really like the brain-dead population. If you looked at our survival, and this is a period from October 2012 to 2016, so it's a 4-year period where we did 120 heart transplants. Most of them were the cold stored hearts, as you can see in the blue bars. This was at that stage we'd done 9 marginal brain dead donors using the OCS, and I should emphasise that these are hearts that really had been rejected by other transplant units or would otherwise not have been retrieved or transplanted. And all those hearts have worked well initially, but we had 1 death at just over 3 months from infection and another death at 1 year from recurrent rejection. In the DCD cohort, which now is up to 15 patients, we've had no deaths, touch wood, to date. Now, having established our program, there's been a lot of interest in other programs internationally developing following this. And the UK have now 3 programs in the UK have started their programs. So there's Papworth, who've had a long-standing interest in this area. They've now overtaken us. They've done 28 DCD transplants. 14 have been with institution of this ECMO in the donor after death. This what we'd still regard as a very controversial procedure. And another 14 have actually been using the protocol that we developed, where you just place the heart on the machine. Harefield have used our protocol, and they've performed 6. And now Manchester they started their program a couple of months ago, and they've performed 2 transplants. And there's a lot of interest in North America and in Europe for developing DCD programs. Now this activity hasn't been without controversy. This is an opinion piece that was published in The Age in Melbourne and the Sydney Morning Herald, written by a paediatric intensive care specialist from Melbourne and a lawyer, basically saying that by restarting the heart, we had basically defied death in these patients, or they hadn't really been dead, and so we'd sort of murdered these patients. So they needed to change the law to protect us, but there hasn't been any further follow-on from this initial report. But as I say, it hasn't been totally without controversy. If you look at heart transplants now, this is data now up to 2016, and if you look at the blue bars, I think you can now see that there's clearly a very significant increase in heart transplant activity. And in 2016, we did more heart transplants we'd ever done previously in the country. So heart transplants are now increasing along with all the other organs with the increasing organ donation rate. And this shows you the transplant activity at St Vincent's, and we really started using the Transmedics machine in 2014, and you can see that since then there's been a very substantial increase in our transplant activity, and last year we did 46 heart transplants. So in conclusion, what I hope I've shown you is that donor characteristics are changing. We have older donors. We face long ischemic times, and we're seeing a much higher proportion of DCD donors. As far as donor heart preservation goes, it's very clear to us that cold storage really produces suboptimal outcomes with these what we call extended criteria donors, but a post-conditioning strategy combined with ex vivo perfusion has enabled us to successfully use these donors. I think really what we really need now is a much better prediction algorithm for determining time from withdrawal of life support to circulatory arrest. As you can imagine, flying interstate, getting set up to do a DCD retrieval, and then have it not progress, and then have to pack up and go home is quite a significant cost and commitment of resources and personnel. I should acknowledge all the people who have done the work. This is the research group in the top left corner there, my clinical colleagues in the transplant program, all the intensive care specialists, and the abdominal retrieval surgeons who made this all possible. And finally, the funding sources. This has mainly been possible through a program grant through the NH&MRC, as well as the John T. Reid Charitable Trust. Thank you very much.
Absolutely fabulous. Thank you, Peter. I'm sure that we have some questions and interaction from the audience. Maybe we don't. Peter, these donors, you didn't mention HLA matching at all, and I imagine there's obviously not a lot of time. And what's the approach to that? Do you just intensify immunosuppression compared with, say, a bone marrow transplant or a kidney transplant, and rely on that to ensure longer-term success?
Yeah.
Or are there some that you do actually know the HLA match?
Yeah, historically, we've never, because of the time frames required to transplant the heart, we haven't had the time to be able to prospectively HLA match. So we don't HLA match our donors and recipients. What we do with Luminex antibody testing now, we do pay a lot of attention to the presence of preformed antibodies directed against HLA antigens in our recipients, and we have an increasing population of recipients who are maintained on mechanical support. Most of those patients have had blood transfusions as part of the implant of the device. So we're seeing a lot of sensitized recipients on our waiting list who've got antibodies. So it's very important to prospectively cross-match these patients with recipients to make sure there's no preformed donor-specific antibodies, but we don't HLA match because we still don't have the time to do that.
Have the time, yes.
Now, having said that, if you look at large registry data, say in kidney transplantation, there is clearly a benefit of HLA matching. But there's also a benefit of minimising ischemic time, and it's just one of many variables that impacts on long-term outcomes.
Yes. Peter.
In relation to your statement about there are more lungs being transplanted than hearts, and obviously the way we manage, and they're in the heart transplants from the patients who are often desperately ill, but the way we manage people with bad ventricles, bad hearts back in the 80s has dramatically changed with more optimal medical therapy. So are we doing better medically now with these people with bad hearts, so that less are coming to transplant, and their quality of life may be somewhat improved compared to previous, whereas when you've got bad lungs, you've just got bad lungs?
Yeah, look, it's a very good question, and as you know, in the 1980s we didn't really have any effective medical therapy for advanced heart failure, but ACE inhibitors, beta blockers and the like have really had an enormous impact. But as you know, these are not cures to chronic heart failure. They prolong survival, but these people ultimately come back, except that when they come back, it's 10 or 20 years later, and they're that much older, they've got a few more comorbidities and other complexities that just make it a more complex assessment in terms of their suitability. The other big impact, or the big change since the early days of transplantation, has been the advent of much better and more reliable mechanical heart pumps, what we call ventricular assist devices. And this is a bit like a Pandora's box, because mechanical hearts are a bit like dialysis for end-stage renal failure. You can have the proportion of people on dialysis is much bigger, or the population of people on permanent dialysis is much bigger than the population undergoing kidney transplantation, mainly because of donor limitations. With heart failure, there'd be potentially more people with heart failure than there are with kidney failure. But we know from experience in the States, for instance, where they do put these VADs into older heart failure patients who aren't being considered for transplant, your survival on a VAD, if you're over 65 in the States, is the same as your survival on dialysis if you're over 65. The challenge is for the funders, how do you pay for this very expensive technology, or are you prepared to pay for it? But the capacity is there to keep people alive and stable on a VAD for years while they wait for transplant. And if you look in our own program and across the world now, about 40 to 50% of people waiting for heart transplant are on a mechanical pump to keep them alive and stable while they're waiting, because the drugs have sort of no longer working. One of the challenges that's created, and you see this in kidney transplant, is that you refer to donor, you refer to a marginal donor, and you've got a very stable person on an LVAD, and the surgeon will say, well, look, why am I going to take this heart and put it into this recipient who's very stable at the moment? Because if I do that, it may or may not work, it'll be a very complex, and that I'll just wait for a better heart to come up. And the same thing tends to happen with kidney transplantation. The driver there is how long they've been on the waiting list, and they've got to the list, top of the list after waiting for so long, and then they'll say, well, no, I'm not going to take that one. I'll wait for a good kidney will come up pretty soon, so I won't take this older marginal kidney. I'll wait for a better one. And this creates distortions in the system, which don't really affect. Well, it goes to the issue of equity versus utility, and the distortion reduces the utility of our transplants.
Peter, can I ask a technical question about the function of EPO and the preservative solution? What is the benefit there? How does that
How's
work?
it working?
Yeah, how's it working?
Well, the myocardium has EPO receptors as well, and as I showed, or I tried to show earlier on, we think that these are coupled to this risk pathway, signalling pathway, the safe pathway. So this is JAK-STAT signalling that then acts on the mitochondrium to stabilise the mitochondrial membrane and prevent the formation of this mitochondrial permeability transition pore. So there's very good evidence that it has a cardioprotective effect. But again, as I showed or tried to show in the rat experiments that we've done, there isn't any single magic bullet that solves all the problems. It's really a combination. You need a combination of approaches that target multiple layers of the signalling pathway to get the optimal sort of cardioprotective effect. And I think that applies to other organs as well in terms of protecting them against ischemia and reperfusion injury.
Okay, well, if there are no further questions, I think we've been acquainted this afternoon with state-of-the-art situation with cardiac lung donation, and for that we are truly grateful. So can you join me in thanking Peter again? And it's not just with applause that we're going to show our gratitude, but there is a show back here from the organisers. I'm not sure what there, but thank you again. Thanks.
I didn't even know you'd done all those things before.